Good morning. Today we have one thing on hand. Apart from corona, in Gopalapatnam area, algae polymers, there is a gas leak and there were some deaths. Let us all pray for them and follow the guidelines given by the authorities, like wearing the mask which is wet. So if there are any rashes, have frequent baths and fresh clothing. And let us also follow the lockdown measures like staying home and staying safe. Now, let us quickly recap what we have covered in the last class on Escherichia coli. Classification of Enteropathogenic E, morphology of Escherichia coli, its antigenic structure, virulence factors, pathogenesis, toxins produced by Escherichia coli, and various clinical conditions that are caused by Escherichia coli. And we were discussing about the urinary tract infection and its laboratory diagnosis. Okay, now let's go ahead with the class. Last time when we were telling about the various screening tests, grease nitrate test we thought of, catalase test, it is one thing that is common for all Enterobacteriaceae, that is positive. And one thing I didn't mention is triphenyl tetrazolium chloride test. This is a dye reduction test signifying respiratory activity of growing bacteria, causing a demonstration of their presence. And to recall, my guru, Dr. P.A. Jayakar, he has produced a paper on this area. And also, we have a microscopic demonstration of gram-strain fillings of uncentrifuged urine. And one more thing I didn't tell you was dip slide culture method. So it is something like an agar-coated slide. That is where we can save the agar. Instead of a plate, you can just have a slide coated with agar. And maybe a color change you can notice because of the growth of the organisms. Or you can dip it in the urine and culture it and see. But none of these methods are as sensitive or as reliable as culture. And last time, at the end, I was mentioning about the concept of significant bacteriuria. Okay, urine itself is a good culture medium. So a lot of bacterial growth will be there if there's a delay. So normal urine is sterile, but a count of 10 to the power of 5 colony forming units per ml of urine is considered as significant. It indicates infection. Counts between 10 to the power of 4 or 10 to the power of 5 per ml of urine, doubtful significance. They have to be correlated clinically. Low count, that is less than 10 to the power of 4 or more than 10 to the power of 4 or equal. They may be due to commensal bacteria, contamination during voiding, that is the act of maturation itself, if not properly done for the test that is required. They may be contaminated with the skin of the prepuce or skin of the labia. So it may not be significant. But low count also may be significant, depending on the following factors. One, how the sample is collected. If you collect it by suprapubic aspiration, yes, the count may be significant. If the patient is on drugs, maybe antibiotics, maybe diuretic, you have to take a low count also as significant. Bugs, that is infection with gram-positive organisms like Staphylococcus aureus or Candida, the fungi, it's also significant. Low count also significant. And clinical conditions like pyelonephritis, that is hematogenous spread, upper urinary tract infection, acute urethral syndrome, these things also can cause a count which is low but has to be taken as significant. Now, quantitative cultures, they are done by two methods. One is a semi-quantitative method, another is a quantitative method. Quantitative method, a serial tenfold dilution technique is used, and the method is four-plate method. And then you have to calculate the count per ml of urine. It's too complicated for routine regular use in the laboratory. So think of a semi-quantitative method which is routinely used. That is, you take a standardized glue and transfer fixed urine volume, plate them on a non-inhibitory medium, that is blood agar, and a selective medium like MacConkey. So MacConkey, you see the lactose fermenting colonies, which are of practical shape, like characteristic shape that is already given to you. And blood agar gives a quantitative analysis, whereas the MacConkey gives a qualitative analysis. Next, antibody-coated bacteria test. It is useful to differentiate between the upper urinary tract infection and lower urinary tract infection. Usually, the source of an upper urinary tract infection is hematogenous spread, and in which case you have an antibody that is present against the E. coli in the blood or in the urine. So, how to detect? So, these antibodies are detected by an immunofluorescence method using fluorescent labeled anti-human globulin. So, you can also detect the presence of antibodies that are coated by bacteria. So, you can differentiate between the upper urinary tract or lower urinary tract infection. Meaning, in the upper urinary tract infection, you have these antibodies present in the urine. Okay, to just recollect some differences between upper urinary tract and lower urinary tract infections. If it is lower urinary tract, usually it is the urethra and bladder, cystitis and urethritis. And of course, the manifestations will be dysuria, urgency and frequency. Route of spread is ascending route, and occurrence is more common, and virulence factors like fimbriae, especially P. fimbriae, are available. And if it is upper urinary tract infection, it is the kidney and the urethra, that is pyelonephritis. You have local and systemic manifestations such as fever, vomiting, and abdominal pain. And coming to the routes of spread, both ascending is common, descending route are same. And occurrence, it is less common than the lower urinary tract infection. And virulence factors, capsular, that is K antigen, that is same. Coming to the laboratory diagnosis. So we have seen so many conditions that are associated with Escherichia coli, and the sample depends on the site of infection. Maybe urine, if it is diarrheogenic E. coli, that is stool, If it's a diabetic wound, the pus, wound swab, so on and so forth. So what do? Once you collect direct smear, in which you see gram-negative bacilli, and of course, pus cells. Culture, as you are already informed, it can be done on blood agar. That is a medium which is useful for their growth. And MacConkey is a selective medium, wherein you see flat, pink, lactose fermenting colonies. And on the blood agar, you see circular, gray, moist colonies. Hemolysis is very good, but hemolysis doesn't really help in pathogenesis. Culture smear and motility testing. Okay, you know that E. coli is motile. And once you do a gram stain, it is gram-negative bacillus. Biochemical identification, I told you the mnemonic plus, minus, that is Escherichia coli for in weak and all, methyl red, prosper, and citrate utilization. And also think of urease production. It cannot produce urease and it cannot produce adhesion sulfide. And of course, another thing that we are going to add is TSI, triple sugar iron agar. If you remember, TSI, A by A unit. A by A, that is sufficient. Anyway, we will deal about the same in your practical classes. Sugar fermentation test ferments most sugars, and typical strains of Escherichia coli, standard strains of Escherichia coli, will not ferment sugars. And next is antimicrobial susceptibility testing, usually called as AST. Coming to AST, it is done on Muller-Hinton agar. Muller-Hinton agar is a bit costly, but while you're asked in Viva or while you're writing about antibiotic sensitivity test, you should write it as Muller-Hinton agar. Don't say nutrient agar, because it's not intended to do antibiotic sensitivity testing. And what is the method? Kirby-Boyer's disk diffusion method, wherein you observe the zone of inhibition and compare it with standard zones of inhibition by various antibiotics for Escherichia coli. But you must remember one thing. The Escherichia coli, they develop resistance to multiple drugs immediately, easily. Many strains of E. coli are beta-lactamase producers also, such as ESBL, that is extended spectrum beta-lactamase, or metallo-beta-lactamase producers. So, the local antibiogram of the E. coli should be considered before you say this antibiotic is effective or this is not. Okay? Now, we have already talked about the localization of UTI, whether it is in the upper urinary tract or the lower urinary tract. Coming to the treatment part of it, uncomplicated urinary tract infection caused by antibiotic susceptible E. coli, usually cotrimoxazole, twice a day for 3 to 5 days, or ciprofloxacin 500 milligrams twice a day for 3 to 5 days is recommended. Anyway, this is to be confirmed by the local strains antibiogram as such. Now, let us see about the diarrhegenic E. coli. One thing you must remember, they are not like the resident colonization forming Escherichia coli that are normally present in the fecal sample. So, most of the time, to report that Escherichia coli detected in fecal sample means nothing, because you have to do a serological typing to say that so-and-so type of diarrhea, maybe EPEC, maybe ETC, or enteroinvasive, or enterohemorrhagic. So you have to do that type of test. Just giving a report that E. coli is associated or E. coli is isolated in fecal sample doesn't go well with a microbiology laboratory of standard. So only few serotypes of Escherichia coli express the enterotoxin or other virulence mechanisms causing diarrhea. As we know, there are 6 types, that is EPEC, enteropathogenic Escherichia coli, ETEC, that is enterotoxigenic Escherichia coli, EIEC, that is enteroinvasive Escherichia coli, EHEC, enterohemorrhagic Escherichia coli, and EAEC, that is enteroaggressive or aggregative Escherichia coli, and DAEC, that is diffusely adherent Escherichia coli. Now, let us see about enteropathogenic Escherichia coli. They frequently cause infantile diarrhea, that is in infants. By definition, infant means below 1 year of age group. Usually they occur as institutionalized outbreaks, and occasionally they cause sporadic diarrhea, and adults also. Person-to-person spread is seen, so personal hygiene is very important. It is non-toxigenic, non-invasive. Remember these words, non-toxigenic and non-invasive. Okay, let us switch over to the other clinical condition that is important. So attachment and effacing lesions, they are said, and it is under genetic control, LEA gene, and also adhesion is helped by bundle forming bacilli, which form cup-like projections called pedestals. Clinically, a watery diarrhea, disruption of the brush border epithelium, if you see pathological slide preparation. Okay, so it is caused by specific O antigen groups. There are some numbers, but it is difficult for anyone to remember the numbers. So you can say specific O group are responsible, and diagnosis by slide agglutination by specific monovalent or polyvalent EPEC O antiserum. This you can write for all the diarrhea E. coli. Just say slide agglutination by specific monovalent or polyvalent O antiserum. That gives proper diagnosis and it makes up a very good answer. What is the pathogenesis? 2 mechanisms. One is EPEC adherence factor, EAF. Another is LEE. That one was we're already referring to. There is a locus of enterocyte effacement. So it is genetically decided. Activity on enterocyte membrane, disruption of freshwater microvilli. So LEE and EAF can be diagnosed by PCR, that is polymerase chain reaction. Coming to enterotoxigenic Escherichia coli, ETEC. Usually it is asked as a short notes or a brief notes. It is 2 marks or 4 marks question. So please pay more attention. There are 2 types. One is endemic and another is traveler's diarrhea. Endemic, seen in developing countries, all age groups, mild watery diarrhea, fatal disease similar to cholera. Other thing is traveler's diarrhea. Again, this may be asked as a short notes question. Persons from non-endemic areas visiting endemic areas, caused by again specific host serotypes. Pathogenesis, adherence by CFA. There are about 1, 2, 3, 4 varieties. So CFA 1, 2, 3, or 4. And it is toxigenic. We have already discussed about heat labile toxin, that is LT, or heat sensitive toxin, heat stable toxin, ST, or both. So LT or ST or both. Diagnosis of both the ST, stable toxin, and verocytotoxin, they can be detected by polymerase chain reaction. Most common, and 25 to 75% of the cases. And of course, as I told you, it's difficult to remember the numbers, but 06, 08, 015, 025, 027, 053, 0159. Again, it is toxigenic, but not invasive. Okay, rest of it we have discussed earlier, the CFA 1, 2, 3, 4, and diagnosis by detection of the toxins. And in your routine textbook, that is Anantanarayan, 10th edition, there is a beautiful table giving about the differences between assay differences, the methodology of doing assays between LT and ST. I think you may not be asked so in depth at undergraduate level, but still, better you know that there are some in vivo tests and some in vitro tests, and in vivo tests, ligated rabbit ileal loop, and in vitro tests, the tissue culture tests, rounding of Y1 mouse adrenal cells, elongation of Chinese hamster ovary cells, or serological tests, that is ELISA, and also you can use passive agglutination tests, passive immune hemolysis, precipitin, that is Aiken test, genetic tests like DNA probes. So you refer to the tabular column about the differences between heat labile toxin and heat stable toxin. But I again tell you, this much of depth is not really necessary. Now let us see about the enteroinvasive Escherichia coli, EIEC. They resemble the alkalizins dispar group. And why that name? Capacity to invade. So, capacity of invasion only is present. It is non-toxigenic. Cannot produce a toxin. So, invasion of the intestinal epithelium, like Shigella, hence the name. Ability to penetrate cells is plasmid regulated, and it forms a diagnostic tool also. If you recognize the plasmid, yes, you have diagnosed enteroinvasive Escherichia coli. By our routine simple techniques, you remember the NNN in parasitology. Here, remember it as a mnemonic, non-motile, non-lactose fermenting, and negative LDC, lysine decarboxylase test. So these three form the mnemonic for enteroinvasive Escherichia coli: non-motile, non-lactose fermenting, negative LDC. Molecular serotyping, invasion of HeLa, HEP2 cell cultures is diagnostic. Old-time examiners still prefer asking what is Serenus test, because it is done on an animal. Remember, animal rights, there are activists and also forms an ethical issue, even if you do a small test, that is putting the bacterial culture to identify, and which causes mucopurulent keratoconjunctivitis in the guinea pig. It is only for completion's sake I am telling, it is not done anymore. So again here, this is from a different source, that is Apurva Shankar Shastri, textbook of microbiology is good. So you call these EIEC, it's not toxigenic but invasive, and these are called virulence marker antigens. So the plasmid, that is plasmid coding for that is called a virulence marker VMA, and this can be detected by a PCR. Manifestations, as we already discussed, it is like Shigella, diarrhea with mucus and blood, called bacillary dysentery, resembling shigellosis. So detection, we said by ELISA about the virulence marker antigen, HeLa cell invasion assay. Serenity test, it is only for completion's sake. Don't do those tests, or don't say that we are doing those tests. Now, coming to enterohemorrhagic Escherichia coli. Again, this one you must remember, O157H7. That is very important, O157H7. And also O26 and H1. Pathogenesis is by two potent toxins like VT or SLT. SLT is Shiga-like toxin. VT, as we already discussed, virotoxin or virocytotoxin. And signs and symptoms, mild diarrhea to fatal hemorrhagic colitis and hemorrhagic uremic syndrome, HUS, especially in the very young or elderly patients. These things are seen. The primary target appears to be the vascular endothelial cell, because the characteristic lesion in the kidneys is capillary microangiopathy. So please remember why it is called enterohemorrhagic Escherichia coli, because the target seems to be vascular endothelial cells, and the typical lesion is a capillary microangiopathy. If you remember this, you have answered your question very well about enterohemorrhagic Escherichia coli. Now, how do you do a laboratory diagnosis? Detection of the virotoxin directly in the fecal sample, or you can culture the fecal sample and the isolates you subject them to detect the production of virocytotoxin. But is there a way by which we can say that it cannot be EHEC? Yes, there is. So you can't go on wasting your laboratory resources. So if you prepare a medium called sorbitol MacConkey, it is good for screening for O157 VTEC. Why? It won't ferment sorbitol. It won't ferment sorbitol. So it's a good screening technique. So if you see that the given fecal sample is not fermenting a sorbitol MacConkey medium, that is taken as a screening test. So, how actually do diagnosis? Conventional real-time PCR with specific DNA probes for VT1 and VT2 genes, and also the cytotoxic effect on Vero or HeLa cells. You know, the Vero cells, African green monkey, are derived from, and also the HeLa cells, that is HeLa, the name came from Henrietta Lane, a patient. She died of a cancer of the womb, and the cell lines from her are being used in laboratory diagnosis of various cancers or invasive oncogenic conditions. So, even though she died 60 days ago, she's still alive in our biological laboratories. Sorbitol MacConkey agar, as I repeat again, in contrast to the other E. coli, does not ferment sorbitol and produces pale colonies. Apart from that, if you can remember, rainbow agar, O157 strains appear as black colonies on this medium as a negative for beta glucuronidase. So remember, sorbitol MacConkey agar, that is a good screening method. If you can remember, rainbow agar also. Good, that's good. And toxin detection, as I told you already, the cytotoxic effect on Vero cell lines is a gold standard. And fecal toxin detection by ELISA or some test. And you can do a PCR also. As I was telling you, please write the words ELISA and PCR. You are almost always right in the laboratory diagnosis of viral infections or EH, EC, or ETEC, or any of these diarrhegenic Escherichia coli. Now coming to enteroaggregative Escherichia coli. Sorry for the typo. I wanted to type this as aggregative, but it is aggressive that I typed wrongly. Sorry for that. So please remember this as enteroaggregative Escherichia coli. If you remember the word aggregation, if you remember the roller formation of red blood cells in your physiology days, same mechanism here also. It is so named because of its adherence effect towards the HEP2 cells is a distinct pattern, layering of bacteria aggregated in a stacked brick fashion. Stacked brick. అంటే ఇటుకలు ఒకదాని మీద ఒకటి పెట్టినట్టుగా. నాణ్యాలు ఎలా అయితే ఒకదాని మీద ఒకటి పెడితే మనకి ఆ రోల్ ఎఫెక్ట్ వస్తుందో ఇక్కడ కూడా స్టాక్డ్ బ్రిక్ ఫ్యాషన్. మోస్ట్ strains are O untypeable but H typeable. So we have said the O antigen and H antigen. O is somatic and H is flagella. So not typeable by O but H typeable. So enteroaggregative Escherichia coli. Coming to pathogenesis, intestinal colonization. That is what we have to remember. By aggregative adhesion, fimbriae 1. So fimbriae are organs of adhesion, and these are aggregative adhesion fimbriae 1. And it also produces EAST1 toxin. Is it remember? Yeast 1. Yeast being enteroaggregative stable toxin. So enteroaggregative, heat stable enterotoxin. 1. Manifestations, persistent and acute diarrhea are commonly seen. And of course, you have to remember one more thing. O104, H4. This is in Germany, 2011, also responsible for a similar hemorrhagic uremic syndrome, HUES. Now, the last variety, DAEC, that is diffusely adherent Escherichia coli. It is characterized by ability to adhere the HEP2 cells in a diffuse pattern. It is the one epithelial cell lines in a diffuse pattern they adhere because of this diffusely adherent E. coli, is DAEC. Express diffuse adherence fimbriae, which contribute to the pathogenesis. So, as we already know, here also it is A, but there it is aggregated, it is adherence here. So, diffusely adherent Escherichia coli is capable again of causing a diarrheal disease primarily in children about 2 to 6 years of age. So we have seen the 6 varieties. So let us summarize. There is a tabular column in your textbook that is regularly followed. Anantanarayan, 10th edition. What are all the toxins produced by various groups, that is EPEC, ETEC, EIEC, EHEC, EAEC, and DAEC. They have given the properties of each particular toxin and also the symptoms and where exactly the intestinal site that is involved, and of course the serotypes of Escherichia coli causing this condition, causing the secretion of the toxin, and the diagnostic tests. Let us concentrate on the serotypes because, at least for completion's sake, let me tell you. The serotypes, that is Escherichia coli with enteropathogenic nature, O26B6, O55B5, and O111B4. Enterotoxigenic, O6, O8, O15, O25, O167, etc. And enteroinvasive Escherichia coli is not that it is invasive and non-toxic. Thinkers maybe wrongly given information. It is given as non-invasive, but it is invasive. The serotypes O28, O112, O152, O154, etc. And enterohemorrhagic Escherichia coli, O157, H7, O26, H1, and O111. And enteroaggregative Escherichia coli, most are O-untypeable, but they are typeable by H or flagellar antigen. Coming to the diagnostic tests, EPEC, detection of the genes that are coding for ALEE or EAS by PCR. Coming to the ETEC, enterotoxigenic Escherichia coli, both the Shiga-like toxin, it is the heat stable toxin or VT, that is virocytotoxin, they can be detected again by PCR. And invasion assays. So we said the major nature is entero-invasive Escherichia coli. So that is where invasion comes into the forefront. And invasion of what? The cell lines, alveoli and F2. Again, you can do PCR also of this entero-invasive Escherichia coli. And entero-hemorrhagic Escherichia coli, EHEC. To recall, we have said hemorrhagic uremic syndrome, HUS, wherein the target seems to be the vascular endothelium and renal microangiopathy is the hallmark of EHEC. Here again, you can write as real-time PCR and conventional PCR. Coming to diffusely adherent Escherichia coli, we have seen in children only it causes 2 to 6 years of age and less well established as pathogens. So, to summarize, before summary, let me ask you whether you have any doubts regarding these things. So you can send your doubts by email or you can right now ask me any way you like. My email ID is BMK, that is Bala Murali Krishna, PERALA, Perala. So BMK Perala @gmail.com. Okay. So in this class, we have seen about the significant count concept of CAS. Remember, may be asked as a 4 bars question, significant bacteriuria. And also, we have seen the diarrhegenic Escherichia coli, various varieties like enteropathogenic Escherichia coli, enterotoxigenic Escherichia coli, entero-invasive Escherichia coli, entero-hemorrhagic Escherichia coli, entero-aggregative Escherichia coli, and diffusely adherent Escherichia coli. We have seen that particular O serotypes are responsible and specific polyvalent or monovalent O antisera are used for diagnosis. And in different age groups, they may cause. And it may be endemic or it may be a sort of travelers who are coming from non-endemic areas to endemic areas. So, and also it may be invasive, it may be toxigenic, it may be both, may just have an effect of aggregation or diffuse adherence. So these are all the various effects of diarrhegenic Escherichia coli. As I already told you, Escherichia coli is a normal resident flora in your fecal matter. So to give a report that Escherichia coli is isolated in a fecal sample means nothing to a microbiologist. If he is looking for diarrhegenic Escherichia coli. You have to say it belongs to so-and-so serotype by the polyvalent or monovalent sera and specific Escherichia coli O antigenic pattern. So that brings us to the end of session on Escherichia coli. So as I told you, you can bring your doubts on email ID, as I already told you, bmkerala@gmail.com. Thank you for your patient listening, and also please stay home, stay safe, and if you have to come out only on emergency like medical purchasing drugs, do have your ID cards with you so that you can show, and you can also show your prescription, and that gives a believable alibi for you. Thank you. Stay home, stay safe. Okay.
Okay.